I'm very proud to present this scientific activity with you. And I'm very happy to have the panelists, very renowned professors from different parts of the world. Actually, we have started our cochlear implant program at Ain Shams University since 1994 with these pioneers from the otology, audiology, and rehabilitation facilities. And actually, the the cochlear implant team of the Ain Shams University is the first university-based center in the area. And since then, we have different phases of the program. The basic one started since 1994 till 2005, and after that was maintained by the university staff of Ain Shams University. So actually, starting from the very beginning, we applied our basics and the standardized indications and surgical procedure. And strangely enough, we didn't have any problem. We started to have problems with the new innovations. So actually, I am very conservative about the extreme explosion of technology and engineering. And because at that time when we started our program, we didn't have any problem till we started to talk about the angle of insertion, depth of insertion, intraoperative monitoring, and all the new terminology and technique. I'm very happy to have the speakers, but I think Professor Skarzinski is the father. This is your father. Anyway, we have Professor Chaush from Tunisia. We have Professor Skarzinski from Warsaw, Poland. Professor Borisenko from Poland, and Professor Shazli from Cairo University, and Professor Tayyar from Istanbul. Professor Tayyar, actually, we did some modification because he prepared a presentation, and then in order to make use of his experience, I included some of his videos in the presentation. So to start with, we have now the extended candidacy, and I want to know from Dr. Chaush whether how deliberately we can recommend surgeries for non-standardized or non-classical cases. For example, we have the single-sided deafness and non-symmetrical hearing loss. Is there a candidate for surgery or not? We have different systems in Egypt that we follow the protocol of the insurance, the governmental one, and we are not allowed to use non-conventional or non-standard indication, which is bilateral profound hearing loss. So, for example, I want to take the opinion of Professor Chaush. This case had right profound sensorineural hearing loss. The left one, she has moderate to severe, and she gained some benefit from the hearing aid. The speech discrimination on the right side is 0, and on the left side is 80%. Do you think that this is a good candidate for implantation, and at what time we can recommend intervention?
What's the age of the age?
She is adult lady, 35 years old.
Okay. And of course, I think we must do examination to definite the etiology of the deafness on the left side. So perhaps we can, because it is not neurosensorial deafness in the left side. The examination is normal and imaging in the left side.
The imaging is okay, no contraindication for surgical intervention. She presented initially with what bothered the patient is the tinnitus, which is now more or less tolerable. But now she is aiming at having bilateral hearing perception for the directional purposes.
Because it is mixed on the left side, so I think we can have another etiology, another causes of deafness. I think I will interest on the left side before interesting on the right side, and propose conventional hearing aids.
Yeah, she actually is using hearing aid on the left side. She is targeting implantation on the right side.
If left side hearing aids and in the right stem cross bone conducting don't give us a result, we can propose actually cochlear implant in the right side, since she has tinnitus, and we see that we can ameliorate the tinnitus with cochlear implant. But in my country, we don't have experience yet in the single-side deafness or asymmetric hearing loss for cochlear implantation. But we published last year national guidelines, and the Tunisian Society of ENT support this indication in these cases. But we must explain complication to and results to the patients, and then of course we must have no results with the conventional aids. But the government don't support the cost of the cochlear implants.
Professor Skarzinski, you have a different opinion. Are you going to implant this patient on the right side or not?
Of course, left and right. I will tell you why. First thing, there is that we need to divide reimbursement for indication. So, of course, in terms of reimbursement, in many countries could be difficulties. And when there was discussion about single-sided deafness many years back, still in many countries it's not reimbursed. And for example, in that case, it will be, for example, BICROSS system reimbursed in many countries. This is first thing. The etiology must be something special here, because we have full deafness in the right ear, and in left ear is mixed hearing loss. So it could be a malformation. It could be, I need to have CT scan or something to see what's there, because if it's progressive hearing loss, it's also in left ear will be the problem. From indication point of view, right ear there is cochlear implant and it's obvious. Left ear you can even put Ponto superpower and it could work, but there is issue what is there.
But for the time being, she is happy with the hearing aid on the left side.
Yeah, I heard it's 80%, 80% speech understanding of it depends. It is a monosyllabic test, it is a word test, it is a sentence test. So this is also issue, how happy is she and what she could have. So I will definitely put her the superpower device in soft band to see if there's any reaction of the left ear. And I think that she will be more happy with that, because it's 80-90 dB on the air conduction. So it could be not effective enough in the hearing aid, but I hardly believe that it's 80% and SRT. So cochlear implant definitely, but we need to have the imaging and the history, because if it's, for example, some malformation, we need to adjust the proper electrode to, to be accurate.
Yeah. Actually, on the left side, this graph upstairs is the aided audiogram, the pure tone, not the. There is no.
So it's okay, because we thought there is bond conduction.
Yeah.
Okay, so if it's aided audiogram,
Yeah.
so there's no doubt. So this is the full long electrode in the full coverage in the right. Sorry, so it's my mistake. We thought the same because we thought that it's mixed hearing loss. So now it's okay.
So to summarize this case, actually, if the patient, even if it is not supported by the insurance system, and if the patient is a private patient, the surgeon should abide with the desire of the patient not to resist doing the implantation on the right side. Is it okay? All right. So there is another problem in this patient, that she doesn't have any congenital anomaly from the structural point of view, but the size of the cochlear nerve on both sides is less than the facial nerve.
No problem.
Does this change the decision?
No.
Okay.
Maybe if there is the different nerve, I will put the wider electrode, not, for example, soft, but standard, because there you have more chance for stimulation. Maybe only that.
Okay. So another point which we have to discuss in each patient, if you have a problem with the size of the cochlear nerve, still, even if the size is very small, there is still chance to have a stimulation by the cochlear implant. So the available treatment for single-sided deafness, we used to leave the patient without any intervention, especially in our area. But now you have to consider doing cochlear implantation in one side and use a hearing aid in the other side. So in the evaluation point and the workup, actually we have repeatedly many questions, especially the audiological part. We want to know whether there is a residual hearing or loss or not, and we have to exclude central hearing loss. Are you following any protocol to answer these two questions, whether the patient has residual hearing and its magnitude, or the patient has central hearing loss?
In the residual hearing, we make the pure tone audiometry.
Yeah.
And, but after many years of doing that residual hearing, so partial deafness treatment, we also very much like to know how is the speech understanding, because quite often the same hearing with some residual hearing is not the same for younger and older. So if we see that there is residual hearing, but there is in best aided condition in noise, no speech understanding, we go for deeper insertion. So it's first thing. Central, I understand, because central auditory processing disorders is in normal hearing children. Central, it means neuropathy. Yeah? It is this is the question, because central hearing loss is in the brain, so there is a transmission. So maybe it's neuropathy. So it's a bit different story than the residual hearing. Residual hearing is if we have some residual hearing in low frequencies, in mid frequencies, and then we observe the progressiveness of the hearing loss. We observe the cochlear and the history of the ear, and we need to see how are the conditions for putting the electrode. And then we decide it will be shorter, longer, Slim J, 622 Flex to be, and to know what will be not today, but also in the future. Because if we put, for example, short electrodes, like in US were that studies. In the US, the hybrid study was that they put shorter electrode, but after some years, FDA forced them to explant the implants and put longer ones. So this is important to have vision what will be in the future.
Professor Borisenko, do you do any investigation preoperative to assess the central function of the patient?
We do also audiometry, registration of evoked potential before the surgery, and we perform the imagery also, MRI, to see how is the brain before implant the patient. In my country, it's not allowed to put the cochlear implant in the patient with residual hearing and with a single side deafness also. So the indication is bilateral deafness.
Okay, so Professor Tayyar, are you still sticking to the 9 months rule as the youngest age for implantation?
Actually, the FDA approved after 9 months for the cochlear implantation, but in my country, the Social Security company let us to perform cochlear implant after 1 year old. That's why if the patient does not have meningitis or something like that, if we do not have to perform cochlear implant surgery immediately, we have to wait till 1 year old.
Okay. Professor Shazli, you are not doing any functional imaging to detect the central?
No.
No. Because Professor Lobna here, head of ENT department at Ain Shams University, she did some study about the functional imaging, but are still not following it as a routine protocol. So you don't do any specific test for the functional part. So another critical situation, we need to be sure that the cochlear nerve is acting or functional. But sometimes we cannot do, even for adults, we cannot do MRI. What is the other alternative? Professor Skarzynski.
Frequency specified, ABR response for 500, 1,000, 2,000, and 4,000. And also followed with the impedance to see if there is not fluid, if there is not any water, let's say, any fluid in the middle ear. And we do like that, and then we evaluate. Sometimes, of course, the results could be doubtful, and that's why we make cross-checking. We are not fan of ASSR because it's faster. It's fashion in Poland now to do ASSR, but it's so many results which are not comparable, but it's shorter, but it's not easy to identify. So ABR is the still classic way to make but frequency specified. I underline because quite often we have patients that they have not good ABR, and this is the indication for cochlear implantation. And quite often we have a little bit better results in low frequencies, and that's why we do like that. So I fully agree. We don't perform routinely in small children MRI. We make cochlear implant from 6 months and 6 kilograms from anesthesiological point of view. Of course, if there is some issue, we do it later. But we don't do in small children, we do CT. If there is ABR response and if there is CT normal, we do implantation. We don't make MRI in all kids because I agree this is not easy.
So, Professor Bornesco, this is a patient who got traumatic fracture of the inner ear due to explosion in Iraq. And at the same time, he got shrapnels all over the body. So we cannot put him in the MRI machine. How to be sure that the cochlear nerve is not cut at that site?
Usually we perform promontory test. We do this for the patient with vestibular schwannoma, where we can see the cochlear nerve. We should decide if the nerve is functional or not. So before the surgery, we perform the promontory test.
You are still having this machine provided by Cochlear to do the promontory test, or you have another machine?
No, we have another machine which made in Ukraine. And we stimulate the cochlear nerve, and we make a registration of the responses. Okay. In this case, I will do the same.
This is the patient we did actually promontory test. At that time, we had this machine, but recently we have a problem to have a similar tympanic promontory stimulation. This is also another problem. Now we are coming to special situations actually for all the encounters we faced during our program. This is very good for the experienced and very good for the more beneficial for the people in training. If you have, Professor Schausch, if you have a patient with secretory otitis media, with or without tube, what is the, when to interfere, whether are you going to handle the middle ear effusion first before surgery or doesn't matter?
Yes, of course. I try to treat otitis fusion and perhaps medically, then perhaps to treat vegetation, adenoid vegetation in children. And it is important to treat it because to the auditory examination, to have a good examination, audiometric bilent before surgery. But if we can't remove all glue, I do the cochlear implant.
Okay, Professor Shazli, did you face such a case? Even let us say that you put the patient in the table, and then after starting surgery, you discovered actually, because usually there is some time between the diagnosis and the surgery, and you are confronted.
I am always expecting in some patients that they are going to have some secretory otitis media. So as a routine, I never postpone my patient. The only thing that I treat secretory otitis media in advance is to diagnose the patient with severe sensory hearing loss for children. So if the child comes for the first time and he's looking for an advice with secretory otitis media, I have to treat it either medically or surgically, do the audiological test, and then arrange for surgery. But it never, hinders the operation for CI.
Professor Tayyar, yes.
If I examine before the surgery and see that there is otitis media with effusion, of course, if the age is very young, I try to treat it. But sometimes during the surgery, we may see effusion in the middle ear. I have some such kind of case, and I continue the surgery. And now recently I perform a study, and I look at all of those patients and compare with the non-effusion cases. And we could not see any differentiation between both groups, even if the complication or the hearing results.
Actually, we faced 3 or 4 cases where we discovered that the patient got secretory otitis media. It was strange that the congestion and the polypoidal reaction in the middle ear was severe to the degree that we couldn't identify the anatomy. And we spent some time to decongest the mucosa, put steroids, and wait for some time, but the anatomy was too much distorted. So this is just a precaution for anyone. Try not to face the secretory process during surgery, because it will add to the morbidity and it will increase the operative time. Another thing we used to do, that we cut the tensor tympani tendon to allow for the tympanic membrane not to be retracted easily, and we found it very helpful to alleviate the surgery. So it is not a contraindication, but it is a problem to identify the landmarks. An important, crucial point, actually, the cochlear implantation in ossified cochlea. And actually, there is no consensus about what to do and the sequence of events. So, Professor Borisenko, do you have any clear roadmap to how to handle the ossified cochlea?
Usually, we have such situation in the patient after meningitis. The cochlea could be ossified inside, or fibrotic tissue can close the cochlear scala tympani, and it's difficult to put the soft electrode inside the cochlea. In such situation, I use perimodular electrode to put the electrode inside. When we have the patient with otosclerosis, with complete destruction of the cochlea, I use also perimodular electrode to put inside the cochlea, and in almost of the cases, it's possible.
So what to do if you could not identify any lumen?
I try to drill the round window niche to see the lumen inside, and I try to put a guide inside in the cochlea. If the guide goes inside the cochlea, I put the electrode after.
So if you see that there is no lumen from the preoperative MRI and CT,
No,
You
if no lumen, I refuse the cochlear implantation
Okay.
for the patient.
okay.
Only if I see the lumen inside, or even
Yeah,
the
but if there is
small
no
channel,
lumen,
if there are no lumen, we refuse the cochlear implantation for
so
this case.
Professor Skarzinski.
Sometimes it's like that you can see lumen and during the surgery will be no lumen, and opposite. It could happen. If we see ossified cochlea, there is a history how long it took. So after COVID, we have so many after meningitis, but it's less now. I enlarge posterior tympanotomy a lot, and I try to follow the place when there is round window, first thing. The lumen, the place when you could put the electrode, is a little bit different white color. So the place when there is scala tympani is a little bit, how to say, more intense. I have no photo, more intense white to do, and I follow that. And I have 5-6 millimeters. If I go through that and I see the difference in that white, I follow that. I try to take, go in and out. The issue is that you have sometimes tools from different companies. From Medel, there is very nice, the probe electrode with the very navy blue marker. And it's really nice to push and to see. Of course, okay, if you have no lumen, we have now not so many solutions. Earlier, there was the double array, the split electrode, but it's out now. And it was not good result. My father did it, I never did it. You have compressed from Medel, and then you could put 2-3 contacts. It's, in the shorter distance, quite hard electrode. The issue is that you could put sometimes some electrodes inside, but there is issue if there will be stimulation. And sometimes there is no stimulation. It could be facial nerve stimulation, especially with patient after otosclerosis. But there is also issue to see if there is only ossification in the basal turn or is also in the second turn. Because sometimes in the second turn you could have some lumen, and then you go more, let's say, central. The mistake which we could make that we go too outside from the cochlea, on the Stachys tube direction. So there is always the way. And we have also the combined CT, which we don't use so often, but in such cases we use. So we put the electrode and we could make intraoperative DCT. And then we see how the electrode is located. If it's not, for example, in the inner acoustic meatus, because it could happen. So it's always the trick. If not, we don't perform ABI. I know that there are centers who performs ABI, so it's an option to do the ABI also.
Professor Tayyar, this is a case where there is bilateral ossification, but on MRI there is some fluid in the basal turn of the cochlea. Both of the ears are profound sensory hearing loss.
Yeah, we can perform surgery.
Which side you start, whether you
I prefer-
operate on one side or both sides? And as
Again.
mentioned, the use of gauges or some instruments to explore the patency of the basal turn is helpful and sometimes essential. And you can choose other options for insertion of the electrode, whether bifid electrode or middle turn insertion. But in such a case, which side to start with, or whether to implant both sides, and if you are going to do it simultaneously or sequential, what do you think?
Okay, if I work with Social Security company, I cannot perform bilateral for the adults. So I have to choose one ear. But if the patient pay himself, of course, I can think about the bilateral surgery. But I think I start with the left one to be sure about the results, because in the left ear there is some fluid in the basal turn, and I prefer to use some short electrodes, some straight electrode, I think.
Yeah.
Flex
But
is
as
not good for
mentioned
such
before,
kind of case for
the stylated electrode is more robust, and it will help you to overcome any physical resistance. It is better than the lateral wall electrode.
Yeah.
But you have, of course, to choose a shorter one in order to avoid the problems later. So again, we have this problem because actually the companies are not supporting us with the gauges or the test electrodes, which we had it sometimes, we used it. Because all the new versions of the electrodes are very flail. If you just try to pass the obstruction, deformity is very high. Yes.
That from Medel, I don't want to advertise, but really the new probe electrode with on the one side you have different flex types, on the second side there is the navy blue, is the a little bit very brutal, but it's very nice tool. It saves free of my surgery, really. In free surgery, I had probe electrode with flex. I couldn't manage. I tried to make something, and I revert that and put that, and it went. So it's really nice.
Yeah, it is very helpful, I think. And,
very helpful. Always it's good to have the probe electrode,
yeah,
because it's
otherwise it will end very drastically. If you try to probe the basal turn of the cochlea with the actual electrode, the result is not very good. Okay. So we said that the electrode in such cases, preferably stylated one, short electrode, and the technique depends on the what lumen you are going to find. But the advice here is not to try to investigate the patency with or to assess the patency with the actual electrode. Another point here, Professor Tayyar, do you recommend doing a drill out in such cases?
Yeah, actually, I try to understand. Yeah. I do not have any experience on double array electrodes, so maybe other colleagues.
Yeah, I'm talking, double array is okay, although it is tricky in the programming. But we still that we can have the dummy probe is very important. Double array is still an option. Doing a stylated electrode is also advisable, but I am talking about the drill out technique.
Okay.
If you don't have any lumen and you are doing a drill out technique as previously described by Balkany and other people in the 1990s,
Again,
to make a tunnel around the modulus and they just bury the electrode.
Actually, I did around more than 700 cases, but I did not have any experience on this.
You didn't. You didn't.
No,
Use.
I did not do so. Maybe the other colleagues can say something more than me.
Yeah. Any one of the panelists has experience with the drill out technique? Yeah.
I don't believe in drill out. I mean, you have ossified nerve endings. It will never work. Even if you put a 6 millimeter electrode in, it will not work.
Professor Borisenko.
I have only one patient where we put this double ray electrode with, in the case of ossified cochlea, and the result was poor. So I don't have so much experience, only one.
Yeah. Actually, this was suggested as an option in the early times in the 1990 or before. But actually, nowadays, it is stated very clearly that it doesn't have any place, because actually drilling this track will destroy the neural element. So definitely you will end with a very bad result. So now it is not an option to offer for the patient to have a drill out technique in ossified cochlea. Professor Borisenko, I know that you are interested in the otosclerosis. So what do you suggest to handle otosclerosis cases if it looks like this appearance and the patient has profound sensorineural hearing loss?
Usually in such cases, it's possible to perform the cochlear implantation. We do cochlear implant in this patient. We have this 10 patients with cochlear otosclerosis after cochlear implantation with the good results. We use perimodular electrode with stylet to put inside the cochlea. It's easy, I think, than you use the smooth electrode in such cases. So we need to drill the round window niche to see the lumen of the scala tympani, and usually it's possible to find the scala tympani and insert the electrode in the scala tympani. We have the cases with complete destruction of cochlea, but in the CT scan, usually we can see the lumen in the cochlea.
Another problem with the otosclerosis case is that the sclerotic focus may affect the round window at the same time.
Yeah.
So it is important to exclude this change at the same.
So,
and of course, you said that we'll use a premodular electrode.
We need to drill more in these cases to see the lumen inside. When we use the perimodular electrode, we didn't see in any cases the facial nerve stimulation. So in our
because you are afraid of facial stimulation.
Yes, yes.
In these cases, it is high possibility because of the rarefaction of the bone and the proximity of the facial nerve. Okay.
Yes.
So in otosclerosis, you have to consider seriously the type of implant. You can use the split electrode array beside the suggestions, and the inverse approach sometimes is resorted to if you cannot find the loop. As we mentioned, facial nerve stimulation, we have very interesting case. This patient was implanted in 2005. After 20 years, he started to have facial twitches. And it was annoying him too much because whenever he put the processor on, his face starts to twitch. And when we did the imaging, we found that the electrode is very close to the labyrinthine segment of the facial nerve. This is the labyrinthine segment of the facial nerve, and this is the electrode in the ascending part of the basal stair. After that, the patient developed facial paralysis. So Professor Borisenko, how to help this patient?
We need to
After, of
switch
course, deprogramming and the
reprogramming.
cancellation of this electrode didn't help.
You will start with a conservative treatment with steroids and diuretic to
improve the facial function.
improve the facial nerve function. If it doesn't work, maybe facial nerve decompression in such cases. If the function of the facial nerve doesn't improve in 1 month, maybe we will decide to make the decompression of the facial nerve
Remove the electrode.
and remove the electrode, maybe.
Professor Shazli.
Yeah, I do suggest translabyrinthine transposition of the fascia posteriorly. You go to translab, leave the implant, you cut the greater superficial petrosal and remove the facial nerve. He's already have facial paralysis. I will go out.
Now he partially recovered. So you
I will
cannot
think about it.
sacrifice
I
the
mean,
facial
I had a case like this and I didn't do it, but I do think about a transposition of the facial. Translab, transposition of the facial, and keep the cochlea apart.
This is a good way of thinking, but although the intervention is very major one,
يعني
and
ده الحل. You have to.
you cannot do the translab decompression through the middle ear. You have to go
لا
middle fossa.
Suzomastoid, transmastoid, translab, transposition posteriorly.
Okay.
I would think about it.
I think it is more easy to remove the electrode, put another perimodular one, which will be kept away from the area of stimulation.
Do you think that you can put another one with fibrosed cochlea?
It is
inside?
difficult because actually the imaging showed that there is partial occlusion, but still, if you have the gauge, you can probe the space for the short electrode. I think it will be less invasive than the other one. So, Professor Tayyar, we want you to comment on the your soft tissue approach. I don't know why it is not working. Yeah,
Okay.
this is a video of Dr. Tayyar, and actually we used it instead of my own one because there are a lot of educational points in his videos.
Yeah, I prefer to perform incision just in the retroauricular sulcus because it is good for cosmetically, and also I cut the periosteum about 1 centimeter far from the first incision. It is, for me, it is good to be safe for the receiver. And to different level suturing give us some advantages for the future, I think.
Yeah, you are doing seat in all your cases,
Yeah, all of my cases.
but
yeah.
no tie over.
All of my cases, I do this incision.
No, I mean the seat for the receiver stimulator. The
I'm
seat.
sorry, the bed. Okay, I do bed for the, I mean, as a canal for the electrode, and bed for the first part of the receiver, on the front part of the receiver, just for that.
But
You
you
see
are
here.
using
You
the
see here.
Yeah, you are using the pocket technique,
Yeah, yeah.
but you are doing also the seat for the receiver.
Absolutely. Just the first part of the ground electrode part of the receiver, I
Yeah.
do some drilling.
Anyone of the panelists using routine seat and tie over in all the cases?
I use a routine incision as type incision to make to drill the squama to make a bed for the cochlear implant. It's easy for me to do that.
Yeah. Actually, we saw some cases where the device migrates toward the auricle, as you see in this case. And it is a very bad situation because it is a primer to have skin tissue necrosis or whatever. So in my mind, I think it is important to have a good security for the receiver stimulator, even with use the tie over or any sort to fix the implant in place.
Yeah, earlier we performed always the bed, and cut was like that, was retroauricular, and now it's 2.5 centimeter. When we have nicer implants, so they are smoother, a little bit wider, but they are not as much elevated. The skin is easier, independent from company. So we always do the indentations of the groove for the wire. This is always, because if you have straight angle with the electrode, then it will be broken in future. We smoothing the first part of the electrode, so we have that bond a little bit, that the implant will not go too anterior. But the issue of migration of that swimming implant is to have a good packet. It means that sometimes we do it at the beginning, sometimes later, so we don't elevate the periosteum, first because you could have hematoma and bleeding, so wide, and we put the implant inside, especially in small children, because if we open it widely, then we could have swimming implants. So the periosteal pocket is really, really very important to have it not as big. There is a risk of the bleeding if we don't make it. But if we elevate the periosteum, we start to drill the bed, we could have much more problems with the hematoma later and with the swimming electrode.
Okay.
Not electrode, implant, sorry.
If you have a problematic anatomy, either hypoplastic cochlea, anterior displaced facial nerve, or prominent sigmoid sinus, difficult round window and posterior tympanotomy approach, do you think, Professor Shazli, that it is possible to do another non-mastoidectomy approach?
I mean, most of the cases, like prominent sigmoid sinus, it's easy to displace the sigmoid sinus posterior. If you go a little bit behind the sigmoid sinus, remove the bone, make an antrostomy, make an island over the sigmoid sinus, you can decompress the sigmoid and get it back. I think if the only thing which may be a little bit problematic is the facial nerve crossing over the round window. In such way, you may use, I didn't face such a big problem before, you may use an anterior tympanotomy, you can use a cochleostomy endoscopically or macroscopically, and then you deliver your electrode inside the cochleostomy versus the round window. Let's go for the hypoplastic cochlea. I mean, it's a little bit difficult. You have to introduce much more electrodes as you can, but I mean, as long as the anatomy allows you, you go for it.
So if you have a hyponematized mastoid, Professor Borisenko, hyponematized mastoid with hyponematized facial recess, and the anatomy is not very favorable, is there any way that you think of modifying your approach?
Usually, we need to drill more to remove more of the bone. More difficult is the case of middle ear adhesion, where we don't have the mucus in the ear cavity and in the mastoid. It's difficult to find the anatomical point, and it's difficult to go inside the tympanic cavity. In such cases, we should find the bony anatomical mark to see where is the lateral semicircular canal, the incus, to perform the posterior tympanotomy and go inside the tympanic cavity. Usually it's possible to do.
Yeah. Professor Skarzinski, what about this case?
First, if I see ossified in the not aerated mastoid, I take the plugs to my ear because the noise exposure during the drilling, because it's a longer story and there is, much less difficulty, and always dura is your friend. If you are lost, you go superior, anterior. And in the cases when you are, I come to that case with the problems, I sometimes elevate the skin from the posterior wall of the external matus. So I follow that and I go anterior and superior. So I go there, never go to posterior. So like that.
Actually, this patient, I think the basal turn is non-approachable.
Yeah, no. This is the issue with I talk general.
Yeah.
In such case like that, always is almost always used in the Charge syndrome, like it was mentioned, the anterior tympanotomy. So if we go from posterior, we go from anterior, we analyze the case, and we do, I think, 800 implants per year, maybe 5 per year. We need to use that approach, to see and to go. And then we analyze from posterior and from anterior in any anatomical conditions if we are able to go or not to go. Sigmoidal sinus is not a big issue if we know that it is, of course. For me, worst issue is dura is going too low, because then, I will not make the dura, to have better approach. And then we could have some decreased visibility, and then there is more often. But there were time 10 years ago that we used more that mixed approach, and now we use it sometimes. In the cases like that, when you have not good approach, you have problem with the fluid, you have problem after, mainly the access, the cases is more problematic after radical cavity. This is the issue, also when you need to go after radical cavity, you need to really identify that, and it's always the challenge to do this. It's possible, but sometimes, I remember the surgery Friday afternoon one time, and all the team thought that we don't perform that, and I found place, I make cochleostomy, I put the implant, and the patient came to me half year later, and I saw his name, I said, "Oh, Mr. Richard, how are you?" "Yeah, you did me implant." And I thought that he was angry. "And how is going?" He said, "It's fantastic. I want to have second ear." But second ear was even worse. So I said, okay, maybe later.
Professor Schausch, do you use any non-mastoidectomy approach?
I always use the standard facial recess approach, but if I have anomalies in the mastoid, I prefer begin with mastoidectomy to have all the repair, the dura, and then if I have a problem, I personally prefer the transadductus approach, even if I must move the ankles and try to pass the electrode from the mastoid to the adductus, and then from trans metal I insert the electrode through the cochleostomy.
Okay, so I think we agreed that the non-mastoidectomy approach is not to be resorted to unless there is a major problem with the standard one. I think I tried only the Varia technique in 2 cases where it's very problematic anatomy, but the trajectory is very difficult, and the possibility of having a problem with the electrode is higher. So I am happy that all of us agree that we have to exhaust our effort to use the mastoidectomy approach before resorting to this. Professor Schausch, do you hear about the rotated cochlea? Do you believe that it exists or not?
I don't know.
The rotated cochlea, where when you open the posterior tympanotomy, you couldn't find the round window in your coaxial vision. This is due to the rotation of the cochlea.
Okay, yes, we don't see the cochlea. It is the round window, so we can do. You can elevate the trans-tympanal flat and try to see it from transmeatal and do the approach transaddutal approach. perhaps with the endoscopes, I don't have experience, but perhaps with endoscopes we can see the round window.
Yeah.
Sinon, we can do cochleostomy
Okay, Professor Tayar, this is your video here.
and have as repair the oval window.
I have one case, sorry. The patient after head trauma, he had a bilateral fracture of the temporal bone and the cochlea was go inside. And it was very difficult to find the round window. And in the first surgery, the electrode was inserted in the hypotympanum. And in the second surgery, we need to remove the posterior wall to make to have a good landmarks, anatomical landmarks, and to find the basal turn of the cochlea. It's a difficult case also.
In your video,
Yeah.
Professor Tayar, you removed part of the external bony canal and you used the microscope through the anterior approach.
Yeah, absolutely. So, first of all, during the examination before the surgery, I mean CT examination, when we put a parallel line to the external ear canal, if we can see basal turn, if we can see cochlea, it means the surgery will be easy. But if not, we may need such kind of different approaches. Like this one. I could not find the cochlea from the posterior approach. Then I moved to the anteriorly with endoscope and find the area and insert. So there is another message here. Sometimes we drill very much to the external wall of the canal, external ear canal. So we have to close this one with a hard tissue like cartilage, something. Otherwise, it is not my own case, but after the problem, I performed the revision surgery. Because of this defect, you see the defect over there. Because of the defect, retraction, then cholesteatoma may happen, and a resident tried to clear the ear, and he took out the electrode. Then I had to perform revision surgery for such kind of case. So the message, we have to close the external ear canal if we have some defect like this.
How often you are using the endoscope with the microscope?
Very rarely.
Very
Very
rarely.
rarely.
Okay. Professor Shazli, do you use the anterior approach with the endoscope?
Yeah, and I never used it. I mean, I have a large series, but I'd like to say something. Most of the presentation which has related to the direction of the cochlear round window aperture versus the lines, whatever, the external auditory canal, the midline, most of them you are talking about bone of the niche. I mean, if you go through a transtegment approach of the round window, you will always find the round window. I have never seen such a big problem of the round window not be seen. Sometimes you make a drilling over the chordal tympani and you make a little bit of anterior displacement to increase the facial recess. In such way, you can approach to such round window. Yeah. So the transtegment approach of the round window is mandatory, leaving the area of the hook region a little bit posterior. You are going to find and come to the round window itself.
So you never had a problem of finding the round window?
No. I mean, the last, I think, like 800 cases, I have never used a cochleostomy.
Any other opinion from the panelists?
Yeah, I agree. But the problem is that I have never a problem with identification of round window niche and round window place. But sometimes, really, you need to drill out sometimes the bone overhang.
That's the overhang.
Yes,
I mean, I'm
this
talking
is
about
overhang,
technique.
yeah. So also, I remember a discussion very hard 15 years ago. One of the professor from Central Europe said, I see round window only in 10 cases of my surgery. And my father said, I cannot see in 10% of the surgery. And that was tough discussion. But really, I always identify round window, but sometimes, for example, in some small children, if I have high facial nerve, I sometimes change the position of the head, I drill a little bit differently, not to hit a facial nerve, but I always want to identify when there is round window and to go in that direction, because it gives us first less chance for translocation. Official publication with all perimodal electrodes are that 35% of that electrodes go for translocation. 35. Professor Melanus from Nijmegen, for example. That's why I don't use perimodal in general. And second is that you go more for the scala tympani. So it's better the superior effect. Of course, if you have some problems, if you have sigmoidal, if you have dura, and if you go a little bit differently, you have the risk of some issues, and some surgeons, they prefer other electrodes, which I respect, and this is good that we discuss. But I think the key issue for good cochlear implantation is to identify where the round window is. This publication from the Craig Bushman and Oliver Radunka from 2006, they analyzed in US when they do cochleostomy. Very nice publication. And it was so big spread of the cochleostomy, and it also was sometimes when there is not good results of the cochlear implantation, because they did cochlear implantation with the cochleostomy, with perimodal electrodes, and sometimes it went not proper way. It was tip fold over or something. So this is why it's always good and to identify round window. Sorry for a long speech.
That's to say, you cannot have a good cochleostomy except if you know what is your round window.
Yes.
This is mandatory.
This is true.
I mean, you cannot, ignore the presence or the sight of the round window and say, hey, I'm doing the cochleostomy. 90% of the case you are going through scala vestibuli. And I don't find too much difference. Going through vestibular tympani, let's say, but you are in this vestibule, as long as you are not sure where is your round. Because the scala tympani goes in such way. After the round window, it goes downward. So if you go for a cochleostomy, sure you are in the vestibule.
Professor Tayar, this is one of your cases where the jugular bulb is extremely high near the round window. So did you diagnose this case preoperatively, of course?
Sure, of course. We diagnose it preoperatively, but I try to perform the routine way to perform cochleostomy. Suddenly, the bleeding come out from the very high jugular bulb. Later on, I wait some times with fresh sponge gel, something like that, and perform mastoidectomy and cul-de-sac, and
you removed part of the external wholly canal.
Yes. Otherwise, I could not go to the cochlea.
So if you have, and this is also one of the nightmares of the new innovations, that we start to use a very fine electrode and we are seeing the tip fold over more frequently. Professor Schausch, do you do anything if you discover post-implantation that there is a tip fold over?
If I discover this complication after surgery, of course, in the setting program, they can not to activate some electrode, and perhaps we have one case, we had a good result in the disactivant electrode. But on the other hand, because we have two cases, we re-explant the patient and reintroduce the electrode, the same electrode, and we did X-ray operatively to verify that the electrode was in the good places. And of course, I think we must did scan or cone beam to see better the electrode when we have problem.
Professor Borisenko, do you use routinely imaging intraoperatively after implantation?
Only in the case there is some problem with activation of implant. We perform CT scan. I have one patient with foldover also, and I think it's one of the last cases. I think we will reoperate it to remove the electrode and put it again.
Okay, I think the coffee break started, so I want at the end to thank the panelists for their generous participation, and thank you very much.